Welcome to the Hospital Medicine Unplugged podcast. Today we are undertaking a critical deep dive into the inpatient management of portal hypertension. Specifically, the evidence-based protocols and clinical nuances required when managing its acute decompensations. This is really an area where our inpatient decisions directly translate into mortality statistics, and staying strictly aligned with the latest AASLD guidelines is, well, it's non-negotiable for improving patient outcomes.
Absolutely. The stakes are profoundly high, and we are focusing primarily on portal hypertension, or PH, caused by cirrhosis, which accounts for, the vast majority of cases we see. We define PH as a pathological increase in the pressure gradient between the portal vein and the inferior cava. But the real clinical threshold, the one that matters for prognosis, is clinically significant portal hypertension, or CSPH. This is specifically defined by a hepatic venous pressure gradient, or HVPG, that is greater than or equal to 10 mmHg. It's that 10 mmHg cutoff that really initiates the cascade leading to varices formation and bleeding.
And those ensuing complications are exactly why these patients land in the hospital, signaling a dramatic and frankly negative shift in their disease trajectory. We're talking about acute varices bleeding, the development of ascites, and hepatic encephalopathy. It's a sobering statistic we must keep in mind. The moment a patient transitions from compensated to decompensated cirrhosis, meaning the development of their first major complication, their median survival drops drastically, from over 12 years down to less than 1.5 years. Our inpatient management isn't just treating symptoms, it's really an attempt to stabilize them back into the compensated phase, or at least bridge them to definitive therapy.
Right, and to manage this effectively, particularly that hyperdynamic state, we first need to appreciate the dual mechanism driving this syndrome. Portal hypertension and cirrhosis isn't a single problem. It's a complex, sort of vicious cycle driven by two interconnected components. The first is the local issue, increased intrahepatic resistance.
That resistance is both structural and dynamic, isn't it? The structural component is the classic textbook definition. The progressive fibrosis, nodule formation, and architectural distortion of the liver parenchyma, largely mediated by the activation of hepatic stellate cells turning into myofibroblasts. This physical remodeling disrupts the sinusoidal pathway, acting like a fixed bottleneck.
Exactly, but physicians cannot ignore the dynamic component, which is crucial because it's therapeutically targetable. The sinusoidal lining becomes dysfunctional, sinusoidal endothelial dysfunction, which severely reduces the local bioavailability of nitric oxide, which is, a potent vasodilator. Simultaneously, there's an increased local signaling of powerful vasoconstrictors like endothelin-1. So you have a physical barrier plus a biochemical mechanism actively clamping down on the flow inside the liver, compounding that fixed resistance.
And then the system responds in a way that just makes everything worse. In response to this internal hepatic bottleneck, the body attempts to compensate, initiating profound splanchnic arterial vasodilation. This is driven by systemic release of vasodilatory substances, thought to be related to bacterial translocation and cytokine release from the gut, a classic feature of cirrhosis. This systemic vasodilation leads to a dramatic increase in portal venous inflow.
That increased inflow is the key feedback loop. The liver is already resistant, and now the body is pumping more blood toward it. This perpetuates the overall portal pressure elevation and drives the development of portosystemic collaterals, which are the varices. The final result is the hyperdynamic circulatory state we all recognize. An increased cardiac output necessary to maintain systemic pressure, coupled with a markedly decreased systemic vascular resistance. Understanding this dual pathology of fixed resistance and excessive inflow is fundamental to why our pharmacological interventions actually work.
Okay, so moving from the microscopic to the macroscopic, let's talk about diagnosing and risk stratifying these patients. We know the gold standard for defining CSPH is the measurement of the hepatic venous pressure gradient, HVPG, confirming that 10 mmHg threshold. But for the vast majority of our hospitalized patients, especially outside major liver centers, this is an invasive test. It's generally reserved for specific situations, maybe like planning for transjugular intrahepatic portosystemic shunt or TPS.
That is precisely why non-invasive alternatives are so critical for rapid and routine risk stratification, particularly to identify those who need urgent endoscopic surveillance or primary prophylaxis. We heavily rely on two readily available non-invasive tools that serve as reliable proxies for the HVPG: liver stiffness measurement, or LSM, via transient elastography, and platelet count.
And these tools have specific evidence-based thresholds that we really need to embed in our assessment algorithms. It kind of simplifies the decision to scope or not to scope.
Right. An LSM greater than or equal to 25 kPa, especially when combined with a low platelet count of, say, less than or equal to a 110 by 109L, is strongly associated with both CSPH and the presence of large, high-risk varices. If a patient meets this non-invasive criterion, they absolutely require endoscopic surveillance because their risk of a bleed is substantial. Conversely, and perhaps even more useful in some ways, an LSM less than 20 kPa and a platelet count greater than 150 by 109L can reliably rule out high-risk varices. This potentially allows us to defer endoscopy and avoid unnecessary invasive procedures in some patients.
Beyond elastography, imaging remains the standard baseline assessment. Abdominal ultrasound with Doppler is fundamental. It confirms the presence of portal hypertension through indirect signs like splenomegaly, the presence of ascites, and critically, the identification of portosystemic collaterals. Doppler flow studies are also essential for assessing patency of the portal and splenic veins, ruling out an acute portal vein thrombosis, which can be a precipitating event for decompensation itself.
But despite the utility of these non-invasive scores, we cannot lose sight of the primary prevention mandate. The guidelines are firm. All patients diagnosed with cirrhosis require endoscopic surveillance unless those specific non-invasive criteria reliably exclude high-risk varices. The consequence of missing primary prevention is an acute varices bleed, which transitions us immediately into a life-threatening emergency protocol.
That transition leads us directly to acute varices bleeding, which demands a rapid, multi-pronged approach under strict ASLD guidance. When that GI bleed is called in, the clock starts ticking immediately.
The first non-negotiable intervention is the immediate initiation of vasoactive agents. Drugs like octreotide or terlipressin are used to cause splanchnic vasoconstriction, reducing portal pressure and collateral blood flow. This needs to be started immediately upon suspicion, even before endoscopy, and typically continued for 2 to 5 days depending on hemostasis.
And concurrent with that, prophylactic FeV broad-spectrum antibiotics are mandatory, just absolutely mandatory. We know that infections are the most common precipitating factor for rebleeding, progression of acute kidney injury, and increased short-term mortality in these patients. Ceftriaxone 1 gram daily is the preferred agent, given its coverage against common gram-negative organisms and its efficacy demonstrated in clinical trials, often started empirically before the source of the bleeding is even confirmed.
Let's delve into the transfusion strategy because this represents a critical evidence-based shift in practice. We must strictly adhere to the restrictive transfusion strategy. The goal is to target a hemoglobin of around 7 GDL. Around 7. This is a point where, clinical experience or old habits must yield to robust trial data.
Why is this restrictive approach so essential? It seems counterintuitive when you're managing severe hemorrhage.
Well, it connects directly back to the pathophysiology. The key trial, Preemptive, demonstrated unequivocally that liberal transfusion aiming for HGB 9 or 10 significantly worsened outcomes. The mechanism is that aggressive volume resuscitation and a high hemoglobin target increase portal venous inflow and critically increase systemic blood pressure. This in turn increases the shear stress across the varices wall, thereby increasing the risk of rebleeding. We need just enough volume to maintain tissue perfusion, but not enough to sort of pop the cork, so to speak.
That underlying concept of avoiding an increase in portal pressure is also why we need to resist the urge to routinely transfuse plasma or platelets. Many of these patients present with elevated PTT, APTT, and thrombocytopenia, and there's a strong temptation to normalize those lab values.
And that temptation must be overcome. Conventional coagulation labs do not reliably predict bleeding risk in cirrhosis because these patients often achieve a new hemostatic balance despite abnormal results. Furthermore, the liberal use of blood products adds volume, exacerbating portal pressure problems without any clear evidence of improving hemostasis unless there is severe life-threatening coagulopathy or the patient is undergoing an invasive procedure like TPS.
Okay, so once stabilization is underway, the definitive intervention is endoscopy. Endoscopic band ligation must be performed quickly, within 12 to 24 hours of presentation. This is the cornerstone of acute hemostasis. But for the truly high-risk patients, we need to think beyond immediate banding and consider early intervention with TPS.
This is where the evidence has truly changed our practice. Early TIPS placement, often referred to as preemptive TIPS, is indicated for specific, very high-risk patients and must be performed within 72 hours of presentation. The selection criteria are precise. Patients with Child-Pugh Class C disease, provided their score is less than or equal to 13, meaning they haven't achieved maximum severity, or any patient who is Child-Pugh Class B but presents with active bleeding that is difficult to control.
That preemptive strategy is essentially acknowledging that medical and endoscopic therapy is likely to fail in this high-risk subset,
Right.
and moving straight to a definitive pressure reduction device improves survival.
Precisely. The data shows that survival is significantly improved by preemptive TIPS compared to waiting for failure and using TIPSIS as salvage therapy. We are basically bypassing the critical period of highest rebleeding risk. Of course, TIPSIS remains the mainstay for salvage therapy if bleeding is truly refractory to initial medical and endoscopic interventions, or if the patient has persistent rebleeding within 5 days of initial treatment.
Okay, once the immediate crisis is controlled, we transition to long-term secondary prophylaxis.
The standard here is the initiation of non-selective beta blockers, or NSBBs. Propranolol, Nautilol, or Carvedilol are the agents of choice. Carvedilol is often preferred, especially for patients with large varices, because it provides an additional alpha-blocking effect, contributing to a greater overall reduction in portal pressure compared to the purely beta-blocking agents. The therapeutic goal isn't just to prescribe the drug, but to titrate the dose until the resting heart rate drops by about 25% or to a rate of 55 to 60 beats per minute, provided the patient remains normotensive.
This titration goal is key, but the risk of profound hypotension in a patient already in a hyperdynamic state can be, well, daunting. Are there specific contraindications or monitoring concerns we need to keep in mind when starting NSBBs?
Absolutely. The main risk is reducing cardiac output too much, leading to systemic decompensation, particularly in advanced ascites. NSBDs are generally avoided in patients with refractory ascites because reducing systemic blood pressure can precipitate acute kidney injury. We must monitor blood pressure closely, often requiring a slightly slower titration than in other cardiac indications. For those who cannot tolerate NSBBs, or maybe as an adjunctive measure, repeat endoscopic band ligation remains a highly effective option for secondary prophylaxis.
All right, moving beyond acute bleeding, the management of other decompensation events, ascites, SBP, and hepatorenal syndrome, requires equal attention in the inpatient setting. We'll start with ascites, the most common complication of PH.
Management of moderate to severe ascites requires a strict three-part strategy that we must adhere to during hospitalization. The first part, often overlooked by patients but crucial for us to enforce, is strict dietary sodium restriction, aiming for less than 2 grams per day. This is the foundation. Without it, diuretic therapy is often, frankly, futile.
The second part is pharmacologic, involving combination diuretic therapy. This isn't a single drug show. It requires spironolactone combined with furosemide. We need to be specific about the dosing strategy here.
Right. The goal is often to maintain a ratio of 100 milligrams of spironolactone to 40 milligrams of furosemide. This helps maintain euphosphoram levels by balancing the opposing mechanisms. We usually start low and titrate upward, doubling the dose maybe every 3 to 5 days, monitoring daily weight loss, the ideal being about 0.5 kilograms per day for patients without peripheral edema, or 1 kilograms per day if they do have edema. Close monitoring for electrolyte disturbances, particularly dilutional hyponatremia and hypokalemia from the furosemide component, is mandatory. Severe hyponatremia, typically sodium less than 125 millimoles per liter, may necessitate reducing or temporarily stopping the diuretics.
And the third intervention is procedural. Large volume paracentesis, or LVP, for patients presenting with tense or refractory ascites. LVP offers rapid symptomatic relief, reducing abdominal pressure, pain, and respiratory compromise.
And we must ensure that LVP is accompanied by mandatory albumin replacement if we remove more than 5 liters of fluid. This is critical for preventing post-paracentesis circulatory dysfunction, or PPCD. The standard protocol is to administer 6 to 8 grams of albumin per liter of ascites fluid removed over that 5-liter mark. Failure to do this significantly increases the risk of subsequent complications like renal dysfunction and recurrent ascites.
And when medical management fails, when ascites is truly refractory to maximal diuretics and repeated paracentesis, TIPS should be considered as the next therapeutic step, but usually only after exhausting diuretic titration.
Okay, moving to spontaneous bacterial peritonitis, or SBP, a complication of ascites that carries a high short-term mortality, often approaching 20% within the first month. Diagnosing SBP mandates a diagnostic paracentesis for every hospitalized cirrhotic patient with ascites presenting with fever, abdominal pain, or unexplained decompensation like hepatic encephalopathy or acute kidney injury. A positive diagnosis is defined by an absolute neutrophil count of greater than or equal to 250 cells per cubic millimeter in the ascites fluid.
And the treatment regimen is complex, involving both antibiotics and, crucially, volume expansion with albumin.
Treatment must be aggressive and immediate. We start with third-generation cephalosporins, typically ceftriaxone 2 grams daily, which offers excellent coverage against the common enteric gram-negative organisms. But the intervention that truly reduces mortality and prevents renal dysfunction is the co-administration of 5-E albumin. The protocol here is specific: 1.5 grams per kilogram on day 1, followed by 1 gram per kilogram on day 2. If the patient presents in frank septic shock, initiation of broad-spectrum antibiotics needs to occur within 1 hour of diagnosis, often before laboratory confirmation of SBP.
Next, hepatorenal syndrome, or HRS, the complication with arguably the poorest prognosis. When a patient develops an acute kidney injury, the hospitalist must immediately distinguish between prerenal failure, acute tubular necrosis, and true HRS-AKI, as the treatment paths are diametrically opposed.
That distinction requires the physician to use the current definition of HRS-AKI, which relies on a failure to improve creatinine after an adequate trial of volume expansion, meaning at least 2 days of stopping diuretics and administering 5-E albumin. If they still meet AKI criteria after that trial, we are likely dealing with HRS, and immediate action is required.
The HRS-AKI action plan is dual-pronged: sustained volume expansion exclusively with IV albumin, and prompt initiation of vasoconstrictor therapy.
Correct. The goal is to maximize renal perfusion pressure. Terlipressin is the only FDA-approved vasoconstrictor for HRS-AKI, and it works by inducing splank neck vasoconstriction, effectively reversing the vasodilated state that leads to renal hypoperfusion. However, intravenous norepinephrine is considered non-inferior in head-to-head trials, and in many ICU settings, it is often preferred due to its lower cost, easier titration, and, frankly, familiarity. Terlipressin does carry a risk of ischemic events, so continuous cardiac monitoring is often required with either agent.
A crucial monitoring tip we must emphasize for our peers relates to serum creatinine. We need to be wary of relying solely on the serum level for diagnosis or monitoring severity in these patients.
Absolutely. Serum creatinine can significantly underestimate the degree of renal dysfunction in these patients, particularly if they are sarcopenic and have very low muscle mass. Their baseline creatinine may be deceptively low, masking a substantial drop in glomerular filtration rate. Therefore, closely monitoring urine output, ideally with a bladder catheter in critically ill patients, is perhaps a more reliable indicator of response to therapy than waiting for the serum creatinine to stabilize or fall.
Now let's transition to the management of hepatic encephalopathy, or HE. We must recognize the wide clinical spectrum, from minimal HE, which involves subtle cognitive changes, to overt HE, which progresses to frank coma.
Management starts with a systematic evaluation and correction of precipitating factors. Always rule out infection, especially SBP, correct electrolyte disturbances, address GI bleeding, assess for dehydration, and review medications like benzodiazepines or opioids that may depress the central nervous system.
Once precipitating factors are addressed, the therapeutic cornerstone remains lactulose. What is the goal of lactulose titration in the acute setting? How do we manage that?
The initial acute dose is typically high, maybe 60 milliliters, followed by 20 milliliters every 1 to 2 hours until patient has a bowel movement. The subsequent maintenance goal is titrated to achieve 2 to 3 soft stools per day, signaling effective ammonia clearance. The titration process is often the biggest clinical challenge, balancing clearance with dehydration risk. We should also note that in critically ill intubated patients, especially those who cannot tolerate the high volume or who require faster clearance, enteral polyethylene glycol may be considered as a temporary alternative to lactulose.
And for secondary prophylaxis, to prevent recurrence after the acute HE episode resolves, we add a key antibiotic.
That's rifaximin. Rifaximin is a non-absorbed antibiotic that modifies the gut microbiota, reducing ammonia production. The standard dose is 550 milligrams twice daily. The combination of titrated lactulose and rifaximin is highly effective in preventing recurrence and should be initiated promptly upon resolution of the acute episode, provided the patient can tolerate the oral medication.
Beyond the specific complications, consistent general supportive care is paramount for these critically ill patients on the ward and in the ICU. We must be laser-focused on avoiding nephrotoxic drugs.
This means scrutinizing every medication order. Avoid nonsteroidal anti-inflammatory drugs, or NSAIDs, which impair renal perfusion by blocking prostaglandins, and ensure vigilance with intravenous contrast dye, which can precipitate or worsen existing renal injury. We must be judicious with all other potentially nephrotoxic antibiotics as well.
And a practical point for the ICU staff regarding invasive procedures. We must avoid routine nasogastric tube placement prior to endoscopy in the setting of acute UGIB. due to the significant aspiration risk in patients with altered mental status and coagulopathy. If NGT placement is necessary, it should be done carefully, perhaps under endoscopic guidance if possible.
Additionally, early extubation is key. Patients with cirrhosis who require mechanical ventilation face a substantially higher mortality risk compared to other intubated patients. We must expedite the ventilator weaning process and extubate as soon as safety parameters are met to reduce the risk of ventilator-associated events and mortality.
Finally, ongoing surveillance for disease progression is a continuous requirement during the hospital stay. Regular abdominal imaging, whether ultrasound with Doppler, CT, or MRI, is needed to assess not only for progression of liver disease, but also for critical secondary events like portal vein thrombosis and early signs of hepatocellular carcinoma.
Okay, let's now pivot to the advanced interventions that offer definitive control and serve as bridges to the ultimate cure: TIPS and liver transplantation.
We've established the preemptive role of TIPS in high-risk variceal bleeding, but what are the other primary indications for the transjugular intrahepatic portosystemic shunt outside of the acute bleed setting?
The two main elective indications are truly refractory ascites, meaning ascites unresponsive to maximal diuretics and repeated large-volume paracentesis, and recurrent varices bleeding that is controlled initially but continues to recur despite optimized medical and endoscopic therapy. Basically, secondary prophylaxis failure. TIPS effectively decompresses the portal system, thereby resolving the downstream sequelae.
While TIPS offers excellent control, hemostasis rates are often greater than 90% for bleeding, and it significantly reduces the need for repeated paracentesis, it is a complex procedure with significant physiological consequences. This necessitates extremely careful patient selection.
That is the crucial caveat. The most common significant complication is the increased risk of hepatic encephalopathy, occurring in up to 30% of patients post-procedure. This is due to the shunting of ammonia-rich portal blood directly into the systemic circulation. Therefore, patient selection must adhere to strict guidelines. We must generally avoid placing TIPS in patients with severe liver dysfunction, typically defined as a MELD score above 18, severe refractory hepatic encephalopathy prior to the procedure, or significant cardiac dysfunction like severe pulmonary hypertension or severe tricuspid regurgitation. They simply cannot tolerate the dramatic increase in venous return.
Understanding that TIPS is a bridge or an effective control measure, we acknowledge that for advanced decompensated cirrhosis, liver transplantation remains the sole curative therapy.
Indeed. Transplantation resolves both the underlying hepatic dysfunction and the profound hemodynamic consequences of portal hypertension, often reversing complications like HRS and refractory HE. It provides the patient with, a new lease on life.
The indications for evaluation must be clear and timely. Any refractory complication, refractory ascites, recurrent bleeding despite maximal therapy, recurrent or severe HRS, or HE, unresponsive to optimal medical management warrants, and immediate workup for transplant candidacy. The MELD score is our primary triage and prioritization tool, and a MELD score of 15 or higher should immediately prompt evaluation for transplantation, as this score indicates mortality risk that warrants listing. The outcomes post-transplant are excellent compared to the natural history of decompensated disease, with 5-year survival rates exceeding 70%. However, circling back to our inpatient focus, we must reiterate the prognostic impact of the complications we manage acutely. SBP and HRS are associated with very high short-term mortality. Even with prompt evidence-based intervention, these events mark a severe decline in hepatic reserve. Early identification and aggressive management are not only life-saving in the moment, but also crucial for stabilizing patients sufficiently for eventual transplant evaluation. To conclude our deep dive, let's briefly touch upon where the research is heading and what novel therapies might soon enter our guidelines, aimed not just at management, but potentially achieving true hepatic recompensation.
One of the most exciting avenues involves drug repurposing. Research into statins, for example, is demonstrating their potential to reduce portal pressure and prevent decompensation. The proposed mechanism is their pleiotropic effects, specifically improving sinusoidal endothelial function and increasing nitric oxide bioavailability, thereby reversing that dynamic component of intrahepatic resistance we discussed earlier. If these large trials prove efficacy, statins could become a new primary prevention therapy.
Another area is optimizing fluid management in the chronic setting. Research is ongoing regarding the utility of periodic long-term albumin infusions beyond the acute SBP or LVP setting for improved ascites management, prevention of infections, and potentially overall long-term survival in patients with advanced decompensation.
And finally, we continue to refine our understanding of TIPS timing. While the preemptive TIPS data is compelling for acute bleeders, research continues on the optimal, perhaps even earlier, timing for TIPS placement across a wider spectrum of patients. Not just for bleeding, but for managing progressive ascites and potentially preventing further episodes of HE. Pushing for intervention before the patient reaches profound, irreversible decompensation.
This has been a detailed, evidence-based deep dive into a high-stakes clinical area. Given the robust evidence for the success of preemptive TIPS in high-risk patients with acute variceal bleeding, here is a final provocative thought for you, the listener, to consider.
What systemic barriers currently prevent the more widespread and rapid adoption of preemptive TIPS in tertiary care centers? This often requires a highly coordinated 247 commitment from interventional radiology and hepatology. And how can we better leverage non-invasive diagnostics like LSM and platelet counts to standardize referral to these specialized centers, ensuring patients are identified and scheduled for definitive intervention before they ever present to the emergency room with a catastrophic bleed?
Thank you for joining this deep dive into the guidelines for hospitalized portal hypertension. Our shared focus must remain on rapid diagnosis and aggressive, complication-specific management guided by the latest guidelines, including those from the AASLD, JAMA, and NEJM evidence base.
Applying this current evidence is not just an academic exercise. It is essential to optimizing outcomes in this high-risk population and navigating this rapidly evolving and high-mortality field. We encourage you to review your institution's protocols against the detailed guidance discussed today.